Okay, so the next piece of management for diabetes is monitoring. And then we move to nutrition, exercise, things like that. But in order to know how to manage diabetes, the patient has to know what their blood glucose is from day to day. So that's one of the things we monitor. We encourage patients to monitor their blood glucose daily to several times daily. With type 2, if they're well controlled, they may be actually checking blood glucose daily. Patients with type 1 or patients who have a higher A1c or are trying to get better control are going to do that more often because they want to see what the trends are. So sticking their finger several times a day is frustrating, it's painful, it's expensive, it requires carrying equipment with them. So some patients, especially with type 1, are now choosing to go with continuous glucose monitoring. It allows for tighter control. It can communicate with a phone app. They are expensive. Sometimes we can get insurance to pay for them, but they require commitment and knowledge, and there's an infection risk. We talked about the insulin pump. You're going to have some of the same issues with continuous monitoring. We also, though, know that daily monitoring is to determine med dosing, insulin dosing, typically today. It may also be used to see trends. If my blood sugar is high one time, maybe I just ate donuts for breakfast. If my blood sugar is high at the same time every day, then my insulin dose may need to be adjusted in some way. Another way that we look at trends in blood glucose is glycosylated hemoglobin, hemoglobin A1c. So remember that glucose likes to bind to things. It's sticky, so it binds to stuff. It binds with hemoglobin in the red blood cells. So each day, if you're healthy and your bone marrow is working properly, your bone marrow produces red blood cells, okay? A percentage of those are going to have hemoglobin that is bound to glucose, glycosylated. That percentage depends on the level of blood glucose in the bloodstream at the time. So the red blood cells that I make today, depending on if my blood glucose is in the normal range, then a certain percentage of those are going to be glycosylated. But if my blood glucose is high, the ones I make today, a lot higher percentage of them are going to be glycosylated. So we know that red blood cells last average around 120 days. So once those blood cells are made with glycosylated hemoglobin, they stay that way. So if we draw blood, we're going to measure the percentage of red blood cells with glycosylated hemoglobin, or the percentage of hemoglobin that's glycosylated. Okay. If my blood sugar is high one day, then only that day are more of the blood cells I made that day glycosylated. The rest of the days, it'll be a normal percentage if my blood glucose was normal, right? So that one day of more glycosylated cells doesn't have a really big overall impact on the total percentage of glycosylated hemoglobin that I have at the time of my test. But if my sugar is high a lot, then my A1c, the percentage of glycosylated hemoglobin, is going to go up. Okay. So we look at hemoglobin A1c. Providers sometimes use it for diagnosis. It's not the standard, but sometimes it is used for diagnosis, especially for type 2. It may be used as you're not diabetic at this point, but your A1c is edging up or is moving up, so you need to work on some healthcare, some diet and exercise management. But also it's used for management, for long-term management. And the typical goal is to keep A1c below 7%. Okay. If someone comes in newly diagnosed, their A1C is likely to be, especially with type 2, because remember it's gradual, so it's been going on longer. Type 2 diabetes, they come in, their A1C may be 13. So if now I know I'm diabetic, I'm going to eat right, I'm going to exercise, I'm going to take my meds, I'm going to be really faithful diabetic because I want to be healthy 40 years from now. They come back in a month, their hemoglobin A1c will be lower than 13, but it will not be at target yet because there are still glycosylated cells or more glycosylated cells in the bloodstream that haven't broken down yet. So just make sure that you're aware of that. The other thing is that urine can be tested for ketones. Testing urine glucose is not a reliable measure of hyperglycemia. It used to be done quite a lot before home blood testing was available, but we're talking 100 years ago or close to it. So urine glucose is not a reliable measure of hyperglycemia, but urine can be tested for ketones. So sometimes people who have frequent DKA may actually keep some ketone strips at home to check. Nutrition. Kids with diabetes have the same nutritional needs as other children. They need the same caloric intake. They need the same nutrient intake. They have to balance their carbohydrate intake, insulin, and exercise to maintain their blood sugar while getting the same nutrients. Okay. Meals and snacks are usually timed to coincide with peak insulin action. If a patient is getting continuous insulin by a pump and they don't eat, they skip a meal or skip a snack, they're at risk for hypoglycemia because they're getting that continuous dose. Concentrated sweets and simple carbs are discouraged. You don't need to tell kids that they never get to have some birthday cake, but you do need to tell them how to do that as safely as possible and that they don't need to have birthday cake every day. Okay, so those things should be discouraged. It should be less of the diet, more carbohydrates. More of their carbohydrates should be complex because they take longer to break down. So that tends to slow down the rise in blood glucose. Fat should be less than 30% of the diet because there's an increased risk of cardiovascular disease, and the emphasis needs to be on unsaturated fats. The more unsaturated fats, the better. Saturated and trans fats are not encouraged. Fiber is encouraged, so whole fruits rather than juice, etc., because that actually slows down the rise in blood glucose after meals. It slows down that digestion process. Exercise is encouraged. Exercise lowers blood glucose, so it needs to be balanced with insulin and food. Newly diagnosed patients with diabetes may need to monitor really closely during exercise, especially in an exercise that requires frequent bursts of energy. Morning hyperglycemia is something that needs to be addressed. I told you that we'd come back to morning hyperglycemia when we were talking about adjusting insulin. If a patient is having hyperglycemia when they wake up, the assumption would be that their evening insulin dose wasn't enough and we need to increase it. So if that happens, then their blood glucose usually rises around 3 a.m. So their evening intermediate acting insulin may need to be increased. But there's another cause for that called the Samagi effect. If their evening dose, if they're not eating enough at bedtime or their evening insulin dose is too high, around 2 a.m. they have hypoglycemia, but they have a rebound hyperglycemia because they break down some glycogen. And so they wake up with high blood sugar, think, oh, I'm high, I'm not getting enough insulin. It may actually be the opposite. So if they're having morning hyperglycemia, one of the things we've got to figure out is which is the cause. Okay, are they undertreated or are they overtreated? Or are they not eating enough? My husband has type 2. He doesn't take meds at night, but he was having Samagi effect blood sugars because he wasn't eating enough at bedtime. So now he makes sure to eat, as long as he eats a snack with protein and carbs at bedtime, his blood sugar in the morning is more stable. It's not going up again. So I want you to remember that high blood sugar in the morning doesn't necessarily mean too much sugar or not enough insulin. It can mean the opposite. The last thing I want to talk about in this section of management is sick days. This is most applicable to people with type 1 diabetes. In well-controlled diabetes, the typical viral illnesses may run their course, but it's very common for blood sugars to be higher and ketones to go up during illness. Patients who are sick don't need to omit their insulin. They may need to increase or decrease it. They probably need to check blood glucose more often. Hydration is really critical. If they can't stay hydrated, they can go into DKA more quickly, so they need hydration. Their provider, a kid with type 1, their provider should be notified if they vomit more than one time, if their blood glucose stays above 240, or if they have persistent elevated ketones in the urine. Last thing is anyone with diabetes needs to have a medic alert bracelet of some sort. They need to have some sort of medical ID stating that they have diabetes. Hypoglycemia has been actually confused for intoxication. So they need to have a medical ID. Okay, in the next section, we're actually going to start talking about complications of diabetes.